about distal embolization, it's around the plaque debris or thrombotic material that moves toward the distal arterial tree. And it may be a micro or a macro embolization according to the level of the particles. With 100 micron is being the standard of measuring, and it may be a flow limiting or non-flow limiting according to is it a clinically significant when it occludes the vessels of the Plony level detected by angiography and causing acute event, or a non-flow limiting which doesn't cause any limitation, doesn't require any immediate intervention. And actually it is a matter of embolization that starts from the risk of even the needle puncture at the very beginning of any intervention, and incrementally increases with each of the manipulation from the wiring, castration, ballooning, and with the use of any devices. And looking all together, we will find that stenting, atherectomy, and in addition to the excimer laser, all together they have a highest risk of distal embolization compared to the standard ballooning and wiring system. And it may even induce devastating major level of occlusion, affecting the whole system, starting from the distal part of the SFA popliteal and going down to the below the knee levels. And when we have a comparison of the incidence of embolization, it is figured that the embolization is much more with atherectomy devices compared to the regular stenting mechanisms. And why we are using the stent, the atherectomy devices, although we have this high risk of embolization, because of the many privileges provided by this atherectomy devices, including more uniform angioplasty at a lower pressure rate and less vessel barotrauma, in addition to the lowest level of dissection, recoiling that may need a bail-out stenting, in addition to a disruption of the calcium coat that will help delivering of the drugs in case of using a DCB, in addition to improved luminal gain. And looking together for all of the atherectomy devices, we will find that most of them don't have an aspiration system, except for a few of them of the rotational atherectomy devices. And this was the recommendation by many of the studies that we have to use an embolic protection devices, especially with the directional atherectomy and the rotational atherectomy, because of the high incidence of embolization used with them. And in between the atherectomy devices, there is some kind of differential level of embolization, with the lowest level with the silver hook and the laser atherectomy devices around 3.6 as the highest level, compared to the Jetstream and Diamond Pack 360, which may mount up to 22% of the cases. And globally, we can see that distal embolization is a universal phenomenon that may not even be seen by most of the clinical studies as a complication, because of the average range of around 70 to 100% of the cases will have embolization. And that's why we have in such a study, they did a revascularization of the femoral region, and they put in all of the cases an embolic protection devices, and they figure that all of the devices of the recovered filters, they have a microscopic embolization materials, and they were considered as clinically significant because 90% of the cases were found to be seen by the naked eye. And using also the transcranial Doppler to detect the signals of embolization and revascularization of the superficial femoral artery, they had recorded 100% of signals in such cases. And by the angiography, which is the standard of care in our practice, we will find that the embolization level is much lower than in the other studies. It's around 1 to 5% of the cases. And also by the vascular study group of New England, they have an average incidence of embolization of around 1.5 to 1.8. And this is reportedly as a low level because of many factors like the lack of precise definition in the registry, and many specialists will consider occlusion of a small branch or a collateral as clinically insignificant, and most of the embolizations are microembolization impacted in a small vessels, even in the dorsal arch, which cannot be detected by the final angiogram. And also to detect the embolization by angiography, you may need a magnification, which is not a routine in our clinical practice. And how can we detect the embolization? By the downstream assessment using the duplex, also by the run-off angiography, and again by retrieval of the filters and ensuring that it has any of the embolic materials, which turns out to be positive in 88% of the cases. And how we go with the atherectomy devices, the risk of embolization is counting mainly on the morphology of the lesion, because the risk of embolization increases with the type of the lesion, higher with the CLTI compared to the claudicants, higher with complex lesions affecting more than 3 vessels and reflected by a fluoroscopy time more than 20 minutes, and affecting an outflow vessels like below the knee or below the ankle more than the proximal lesions, long lesions and CTOs in task C and D, and lastly in a patient with a previous history of amputation. And this can have a preventive strategy, of course. Can we prevent embolization? Yes, by using anticoagulation and antiplatelets, antistatins, and also we may use an embolic protection devices like the filters, whether Spider, Embol Shield, or Varion, or using the Proteus capture balloon. And using any of these preventive strategies carries a higher, also a high controversies. Why controversies? Because most of the experts consider or believe that the incidence is low and it doesn't warrant any use of routine embolic protection devices. And also, the majority of the studies has only concised the protection devices for long lesions, single run of vessels, and in association with atherectomy devices that can be used as a routine measure. Also, an algorithm has been proposed for how to deal with lesions for peripheral arterial occlusions, starting with the usual way as Maria has emphasized on, by using firstly the available methods like the wiring, ballooning, and stenting. Even going to atherectomy should be with a high indications, and if you have a definite morphology that demands filter application, it should be calcification more than 4 centimeter in the CTO lesions, ISRs, thrombosis, or if you have a long lesion more than 14 centimeter, or if you have less than 2 of the distal run of vessels. Filters to be positioned 2 centimeter distal to the site of the tip of the atherectomy devices, and it should be oversized by around 10%. So for a lesion of 4 to 6 millimeter, you got to use a filter of 7 centimeter and avoid its entrapment into the tip of the atherectomy devices. Filters has proved to reduce the risk of embolization by reduction of the embolization risk from around 63% up to 2.3% of the cases. And what you will do if you have an evident embolization, you can do a manual suction with a 60 milliliter syringe and 8 French guiding casters, and you can do thrombolysis, mechanical thromboaspiration with angiojet or a Penumbra system. And lastly, does embolization have an impact on the overall outcome? The answer is no, and it doesn't have also an impact on the patency or limb salvage. That's why we don't have to put an embolic protection devices in our routine use in the light of the high exposure of fluoroscopy and the higher risk and the higher costs of the patients. Thank you very much.
Thank you very much.